Well, here we can see the some aspects about epidemiology of diabetic patients. More than 371 million of people have diabetes, and estimate about 440 millions for the next 2030. But the big problem is diabetic foot prevalence, complication is underdiagnosis. You know, here is today the approximately diagnosis is in the 28 to 40%. Next one. And this is the reason why the amputations are the one of the most important alterations in this kind of patients, because they haven't an early diagnosis of the early injuries about the neuropathic diabetic alterations. For instance, if the patient have alterations in the heat, cold, or pain sensations, the threshold of these sensory alterations are not checking, well, this patient go to the possibility of the wound and amputation. The next one. Most of the countries' health system are in development, have scarce epidemiological studies about diabetic neuropathy, and those studies have a lot of difficulties to get a conclusion because the randomized trials value in different studies were not specific, without sample size to recognize the statistical power, as Professor Niels Hager say from the Steno say yesterday, did not comply with agreements of San Antonio 1988 to the diagnosis criteria. Lack of homogeneity of the groups of patients studies, considering the form of neuropathic and metabolic control, the use of the endpoint with higher variability between individual centers are other reasons. In addition to this, suffer from high rate of diabetes as well as other neurological disease in the same time, alcoholism, very, HIV, etc. The more prevalent complication in diabetes is underdiagnosis. Here you can see the situation in the Herman Kennedy study that only 30 to 35% of patients have a diagnosis of low or moderate neuropathy if the people have the usual tools to do this diagnosis. Diagnosis for the endocrinologists and non-endocrinologists are not very different. But when the patient have a severe neuropathy, yes, the number of percentage increase very so high, but this is not the time to do it, the diagnosis. This is very later. And another surprising result was about those studies. In this study, the surprise was the patients do not report symptoms was around 12% and do not receive treatment 39%. And by these reasons, the early diagnosis is very important. And look at this. The last day, Dr. Pedrosa sent for us this slide, very interesting slide about 4 studies, longitudinal and not longitudinal studies, cross-sectional. And in these studies, the authors recognize the pre-diabetes intolerance, glucose, not diabetes, have 11, 13, 49, and 29% of alterations, and in non-diabetic 3.5, 7.4, 29, and 11.1%. But this is very interesting because we arrive very late to do a diagnosis with our habitual tools, and this is one of the reasons that the increase of the amputations and the wound. The consensus and recommendations for establishing the diagnosis is 2 positive tests, I mean to signs, not symptoms, because symptoms sometimes are a wrong diagnosis of polyneuropathy. If we check symptoms on signs, if we get it two signs, we have in front of diagnosis. This is a probable diagnosis that the Toronto Consensus in 2010 of the Neurodiab. And what about the situation that we reviewed yesterday concerning the pathophysiology? Well, hyperglycemia is not alone in this schematic pathogenetic situation. Hyperglycemia and with the lipooxidation remove the oxidative stress, and this oxidative stress make a high lesion in the endothelial cells. And these endothelial cells of the vasa nervorum and the alteration inside of the axon remove the lesion of this kind of sensory motor polyneuropathy in differentiation than other kind of neuropathies. Well, I would like to share with you all the situation in the last year. The Nobel Prize was to two researchers that investigate the temperature, head pain, and the touch perception, and that researchers in the United States can detect the manner that these receptors transform biophysical and biochemical in the skin, the perceptions. And this is very important because it's the biggest steps to the next possibilities diagnosis with other instruments in this kind of patients. Remember, if we are checking the skin with quantitative sensory testing, tiny fork or pinprick or nerve check or method TSU analyzer, we are checking the receptors of the skin, but also the central nervous system, because this is the way to arrive to the cortical area, and the patient give us the replay about our question with the stimulus. This is very important because today we have the possibility to detect these alterations with different devices, that is the TSU analyzer, case 4, check, QST, and or microneurography or other kind of devices. It's possible to make the diagnosis of the phenotype of these patients, and these phenotypes are given to us the possibility to make the personalized treatment. In this case, painful phenotypes have 3 levels. One is mechanical and thermal sensitivity analgesic, the second is thermal sensitivity, and the third is mechanical and or thermal hyperalgesia. If we divided these phenotypes, we can use different kinds of therapeutic, pathogenetic, and symptomatic therapeutic. In the next slide, we can divide it by symptoms, the phenotype, only by symptoms. But we need to make diagnosis by signs. It's not only possible situation make diagnosis by symptoms. We need it, the signs. But in this case, as Dr. Rosenberg from Heidelberg University recommend, burning, head and paresthesias have peripheral central nervous system hesitation, and it is necessary to use a drug to the central nervous system alteration. Very different in burning heat and mechanical allodynia without alteration of the temperature threshold. In this case, the skin receptors are in the normal level of the threshold, and it's not necessary to put the treatment of the central nervous system. This is one example that we will open today, the new possibility to make diagnosis of the phenotype and the treatment personalized. And here is to remember the some aspects of the new device to check in the corneal confocal microscopy, the nerves in the corneal area. And it's possible to make an histogram with these large nerves and to account the nerves and the large of the nerves and the size of the nerves. And we get it, the diagnosis about what are the nerves, the plexus of the cornea in this case, and have a good correlation with the IENF and the QST and electromyography testing. Then in the next slide, I would like to comment something as Professor Gabriela Radulian comment yesterday is about the pathophysiology treatment. We have in our mind the pathophysiology treatment. In this case is the oxidative stress, hyperglycemia, dyslipidemia, and also hypertension, obesity, and sometimes alcoholism. But this is very important because when we have in our mind this pathological situation, we must remember that the most important is glucose. But not only glucose is important, all the risk factors in the same case than myocardial ischemic situations, we need to control. Hypertension, dyslipidemia, I'm talking about triglycerides, fatty acids, cholesterol, LDL, HDL, and hypertension, of course. And obesity, peritoneal obesity, is one of the most important in this case. By this reason, we included treatment of metabolic syndrome. These patients have the same polyneuropathy than patients who have diabetes with only hyperglycemia alteration. And the pathogenetic treatment is, I'm only make a commentary about alpha-lipoic acid. Is one of the most important pathogenetic treatment with the benfotiamine. But alpha-lipoic acid have a lot of studies that demonstrate it is possible to stop the progression in the symptoms of these patients, and it is possible to stop the progression of the alteration in the electromyography and the BPT. That is the recommendations to use, because we will be able to stop, not to recovery, but to stop the lesions. The milligrams to use is 600 milligrams. It's important by the biodisponibility to use in the morning before to the breakfast, and if it's possible to do it also by intravenously treatment. And the other one is the symptomatic treatment as antidepressives, tricyclics, different levels are for the tricyclic for the morbidity of this one. But the most important is amitriptyline, that is one of the level A in all of the recommendation consensus. And the next one is duloxetine, that is the today more useful tool to make the treatment, symptomatic treatment in these polyneuropathy painful patients, because we can use duloxetine in the same time with a combo treatment with gabapentinoid drugs? Well, I think I tried to make a review of the speakers that his excellent conferences about each of these items, each of these topics, does present yesterday.